What does a patient expect to see or get when he or she actually comes in to see me? See, the point is that a patient can be referred to me either by a referring doctor who's been kind enough to feel that maybe I can help this couple and therefore he refers the couple to me, or might just about see me on the website or read up on the material that's available on the website and want to see me. Either ways, when a couple decides to come in to see me, there are certain do's and don'ts, and if you go through them a little quickly and one by one, it makes you more prepared to know what's going to happen to you when you actually walk in to see me. So you can see a number that's scrolling down at the bottom of this video. This is the number to call up if you want to see me. Once you've called up on this number and my person has talked to you, there will be a mutual time that will be fixed, and that's a good time for us to meet. Please make sure as far as possible to come in as a couple, because it's always convenient and I need to ask certain questions which are best answered when you're both of them together. Of course, if you're coming in as an intending single parent, then that's a completely different story. Also, when you're walking in, make sure that all your previous papers, even if they're not important to you, please bring them along. I have enough time to go through all of them, and we might always pick up certain clues or hints as well as some points regarding your previous treatment. Also, because of these days, the legal situation is such, please carry all your documents regarding your stay, maybe a PAN card or a license card or an Aadhaar card in Indian context. If you're a foreigner, you have to make sure that you come and see us on a medical visa. We cannot see patients on a tourist visa because of the restrictions that are imposed to us by the government. So then you've decided to come in, the appointment is done, and you actually walk into my clinic. Now, please keep a couple of hours at hand. It's not that you need those hours, but it's always helpful if you're not rushed, and we can always converse at a good pace, because otherwise if you're rushed and we might miss out something, that's not good for you and not good for me as well. Now, when you walk in with your papers, you're going to be registered as our counter. After having been registered, there's a biometry that needs to be done, just to take your height, the blood pressure, the body weight, etc. And that's good data that needs to be fed into our system so that we can refer to it later on as well. Once all this is done, this may take around 10-15 minutes. You are then ushered into a assistant room. Now, by assistant, it is no means that they are lesser doctors. They are my colleagues. It is just that we are working as a team, and they would like to go through the papers once just to make sure that we haven't missed out anything. And the most important papers are either taken up by them to be lined out separately, or the findings are noted down in another piece of paper. All of these information is also recorded in what we call the software, the Civis software, because this can be referred to at later on also if you've missed out something and we want to come back to your case. Once all this is done, and this might take you around 30-35 minutes, that's when we get to meet. Once I see you, my basic point would be to go through whatever has been discussed or seen by my doctors, see what is the best plan for you. We could discuss in terms of the time that you have at your hand, the money involvements, the success rates, the failure rates, the complication rates. So I'm very happy if you have a fair sense of what may be wrong with you, and you read up on that on Google, and then we can converse. Or maybe the first time around, I give you a sense that maybe this is what is affecting you, maybe a polycystic ovarian syndrome or an endometriosis or a poor ovarian reserve, and we close it at that, and you go back and read up on the net and then come back for the next round of interview. The idea of asking you to be informed about the process or whatever may be affecting you is to make sure that you ask the right questions, and we can narrow it down to a tangible plan as quickly and as efficiently as is possible. So if you are read up on what you are wanting to know, and if you know what you're wanting to ask, life is easy both ways. So as we discussed, once the appointment is taken in and you've been talked to by my colleague doctors and I've had a look at you, usually we come down to the basics. And what are the basics? As I keep saying, there are 5 factors which all have to gel in for a pregnancy to happen. It could be a disease affecting the eggs, the sperms, the uterus, the tubes, or maybe the sex is not happening right. So these are the 5 factors. Either one of them or a combination of them is not going right for you, and therefore you're not conceiving. So mathematically, these are the 5 variables, and we have to find out if any of them is wrong or more than one of them is wrong. The way we do it is we ask for an AMH blood test for the egg quantity. We also do an ultrasound to see if the uterus looks fine and the ovaries look okay to us. We ask for a semen analysis, and sometimes if the tubes haven't been checked prior, we ask for either a sonosalpingogram or a hysterosalpingogram to find out if the tubes are okay or not. Now, I would not go really into details of these, but primarily what I mean to point out is, even if your semen analysis has been done elsewhere, I would possibly insist that we do the semen analysis at my place, because we do it by the newer method. We are more used to that kind of method of semen analysis, and the information that we get out of the semen analysis is actually priceless. So if that's okay with you, please be prepared for a semen analysis as well, so that we can carry this out and be more informed regarding you. Of course, this is not always the case that we need to do a semen analysis on the very first day of consultation. Maybe that can be done in the second or the third visit, in case we think that we need to concentrate on some other aspect of your case. So semen analysis may or may not be necessary on the first day, but something that's surely going to happen on the first day of visit is I'm going to ask for a transvaginal ultrasound, or a TVS. A TVS is a wonderful way of knowing the female pelvis. It's a non-invasive, simple method. It does not hurt. It does not invade your privacy in any sort of a way. It's carried out gently and sensitively, keeping in mind all your concerns, and it gives us a wealth of information. It tells us whether you may be suffering from something called the PCOS, or there could be a chance that you're suffering from endometriosis, or maybe your eggs are less in number. We might be able to pick up something wrong with the uterus which was not detected earlier, maybe a small polyp in the endometrium, maybe a fibroid in the uterus. There could be some fluid in the pouch of Douglas, which is essentially meaning to say that there could be some infection or some collection that was not previously seen or detected or not considered important. All this information actually helps us a lot to plan out your treatment, and therefore with maybe a TVS and a semen analysis and sometimes an AMH blood test, my initial job of investigating and kind of assessing you as a couple is over. With all this information and having talked to you at length, we can then now come down to the treatment options. By and large, the treatment options are of four kinds. We could stimulate the egg production by giving medication. They could be oral or they could be injectables. Once having stimulated the ovaries to produce more than one egg, we can then ask you to stay together on given days. This is known as a planned coitus, or what we say a PC cycle. This is the simplest of treatments and is usually the initial therapy for a majority of couples who have been trying for less than a year, or maybe a couple of years at most, with no discernible cause of infertility. This doesn't take much insofar as costs or treatment time is concerned. The second option that we offer to some of our couples is what is known as intrauterine insemination. Here the lady is stimulated to produce eggs as before, either with tablets or with injectables or a combination. The eggs are then monitored with an ultrasound, the transvaginal ultrasound as I mentioned in the past, to find out whether the size is right or not. And once the eggs are ready, the partner's sperms are then injected inside the uterus. So where husband is away for certain reasons, or where maybe the sex is not happening properly, or there could be a local factor where the sperms are getting damaged or not getting to enter into the uterus, and IUI works fine. This is the second treatment, or we can say the first starting treatment for assisted conception therapy. In case this has already been tried in your case, or we do not have the time for trying for IUIs, because by and large both IUIs and PC cycles do not have a very high per cycle success rates. It are less than 20% success rate. So if couples have come from far, do not have much of a time at hand, then we either recommend what is known as a laparoscopy and hysteroscopy to see if something is wrong inside the pelvis, or in most cases we move on to the highest treatment that we can offer, which is an IVF. IVF stands for in vitro fertilization, the colloquial language being test tube baby. Now don't let the words IVF frighten you. Please understand that we recommend IVF only to the ones who need it and not to everyone. And in my clinic, if I'm seeing 250 couples a month, Only about 50 are being recommended IVF. The rest do not need an IVF and are not being recommended an IVF. As we keep saying, the patients that come to our clinic are coming for a pregnancy. It doesn't really matter whether they conceive naturally through a planned coitus cycle, or maybe with some assistance through an IUI or insemination cycle, maybe through a laparoscopy, or maybe finally through an IVF. A pregnancy is a pregnancy, whichever way you get it. Having said that, we also need to understand that IVF is necessary. It's an important tool to get people pregnant when nothing else is working. In some cases, where the sperms are very few in number, not of good quality, when the eggs have been exhausted largely and very few eggs are left, when the tubes are blocked or unfortunately damaged due to infection or some other reason, IVF is the only one that comes to rescue. And in today's scenario, IVF has evolved a lot. It is no longer as complicated or painful or chancy as it was even 15 years back. The results have improved, not for any other reason, but for the fact that the labs have improved a lot. Machines have become standardized. People working behind the machines have become better trained now because the science is widely available. The injections have become lesser in number. They are less painful, they have less side effects because they are recombinant in nature. Previously, they were sourced from animal sources or from human urine, no longer so. So, all this put together has made IVF a lot more tolerable, let's put it this way. So, when I see couples, they are either recommended for a planned coitus cycle, or an IUI, or a laparoscopy, or an IVF. Now, the IVF has the highest per cycle pregnancy rates. Planned coitus or an IUI does not even come close. It has less than 20% pregnancy rates. So, when somebody we feel may conceive through an IUI cycle and is put through IUI cycles and has failed 2 cycles, he or she is devastated because he feels that he'll never get pregnant. Please understand that the very fact that you were put on a PC or an IUI cycle is because we felt that you may not need an IVF. So in our eyes actually, you are a very good patient. Even though an IUI may not have worked, because there are 1001 reasons why IUIs do not work. We have discussed that in other videos, please go through them. So even if an IUI doesn't work, that is not actually the end of the road. That's the simplest treatment that did not work for you, and we have higher, better treatment options for you. What if an IVF doesn't work? Yes, there are so many couples who walk in for reference, for second opinion, because the IVF has not worked in some other clinic or maybe even with us some time back. First of all, let me make it very, very clear to you that all doctors, IVF or otherwise, wish the very best for you. So if an IVF cycle hasn't worked with us or with anywhere else, it is not because of the doctor's fault. Every month, the egg quality changes. The uterus may not be receptive to receive embryos every month. There are 10 other reasons why IVF may not click in a particular month, may actually work out easily in the very next month. So for a failed cycle, there are other technical solutions also. Again, those are things that we have discussed elsewhere and I would not discuss that now. But criticizing other doctors or finding faults with other doctors or other treatment therapies really don't work. What we need to understand is if an IUI cycle or an IVF cycle hasn't worked, we need to either repeat the same or go ahead with the next treatment option. What we need to remember that end of the road, most of you who walk into the clinics, I would say most again, would go back happy and pregnant. So long then, happy viewing.